TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are here in Orlando, Florida for Anesthesiology 2019, the annual meeting of the American Society of Anesthesiologists. Now, with over 14,000 delegates, this is the largest meeting of anesthesiologists and anesthesia providers in the world. I'm joined today by my co-host and partner in crime yesterday and today, Sol Aronson.
Emphasis on crime, right?
This is criminal.
I know. Don't tell Monty I called you that, because that's usually what I call it. We're, Sol, thank you so much for joining me in TopMedTalk here at ASA.
Always my pleasure.
It's good. It's hard to kind of nail you down, though, Sol. You're crazy busy, and everybody knows you, so it's awesome. It's a good thing. That's awesome.
What can I say?
Yes. All right. So this year, TopMedTalk is here for our third year. We're in Boston and San Francisco, and we're in the trade exhibition this year in Orlando, and our booth location is 730. So if you're around the ASA and you're in the hall, stop by our booth at 7:30. We want to graciously thank our sponsors, Edwards Life Sciences, who is at booth 727. We're sitting here staring at their amazing exhibit that they have. So if you're in the area, stop by booth 727 or 730 and say hello to TopMedTalk and Edwards Life Sciences. We also really want to thank the American Society for Anesthesiologists. They have been really supportive of TopMedTalk and wanting to engage and help us to share the knowledge that we're getting and collaborating with here on TopMedTalk. So thank you to them. Now, we've had some great conversations today with Andy Shaw, with Carol Peden, Mike Scott, Neil Fleming, about all things perioperative care, perioperative medicine, a lot about change management, which is interesting, and implementation science, which I think is kind of hot topics in perioperative medicine. We know that there's a lot of evidence to support a lot of interesting initiatives, but it's really hard to get people to change. So we've been talking a lot about that. So cool stuff. Going to switch gears a little bit, and we've had the opportunity to learn about a company called, or a
Foundation.
Thank you. A foundation called Lifebox, and we were just hearing that beautiful voice from the founder and a trustee for Lifebox, Alex Hannenberg. How are you, sir?
I'm great. Delighted to be with you.
Thank you so much for joining us on TopMedTalk. That's
My
good.
pleasure.
So, Alex, you're not only involved with Lifebox, which is what we're going to deep dive on here in just a moment, but you're also a past president of the ASA.
That's correct. I was president in 2010.
In 2010?
Has it been that long, Alex?
It has.
Oh, my goodness.
It has. It doesn't seem that way, I think, because as part of ASA's recycling program, I was brought back as chief quality officer for a number of years.
I thought it was just because you aged so graciously.
Yeah, exactly.
That's a good way to put it. Recycle. Great. So are you still involved with the ASA?
I am involved with some of the foundations, more so, but I don't hold any real position any longer. But it's obviously near and dear to my heart. I was noting to myself that this morning the governing body, the House of Delegates, met, and I actually went to an educational session, and it was the first House of Delegates meeting in 32 years that I hadn't attended.
Oh, wow.
So it's kind of a milestone.
Mazel tov.
Yeah, right?
Yeah, no, it actually feels good.
Yeah.
I'm kind of moving on, interested in things like Lifebox and simulation and surgical safety. So
I think I see
I'm
some
growing
wings
up.
back here.
Right.
You're fine. Well, okay. Well, tell us about what is Lifebox?
So Lifebox is a global not-for-profit foundation. I usually think of it as kind of the implementation engine for the WHO Safe Surgery Saves Lives campaign, which was launched in about 2007 or so. That event itself quite remarkable because the World Health Organization and kind of the global health community up until that moment had been singularly focused on communicable diseases, HIV, tuberculosis, malaria, and so forth. And I think by the time that campaign was launched, people were beginning to wake up to the fact that more people were dying avoidably from unsafe surgery than from those three communicable diseases combined. So it was a watershed moment that the WHO engaged in surgical care. The project was led by Atul Gawande, a professor of surgery at Harvard and prolific author and general whiz kid. He's the only one I know who's both a Rhodes Scholar and a MacArthur Genius award. So just a general overachiever. And I think so that was a process of bringing together people from many disciplines, from many corners of the world, to identify the priorities in improving outcomes from surgical care. And at the time, a relatively limited data set told us that the rate of mortality, particularly in West Africa, was 100, maybe even 1,000 times greater than it was in our community. And so what are the priorities to address that, recognizing the resource constraints? So as you can imagine, 125 delegates to this from all over the world, nurses, surgeons, anesthesia providers, had many different ideas. And it was distilled to a list of 10 items. And so what do you do with those 10 items to put them into action? And what happened was it was translated into the WHO Safe Surgery checklist. And we have used that checklist pretty much as a roadmap to identify the opportunities where Lifebox needs to be working to improve care. And so the contribution of that WHO project is enormous, but the implementation and delivery of that to operating rooms around the world was something that needed a dedicated focus. And I remember the afternoon I got a text message from Dr. Gawande.
That's cool, by the way.
Right. Yeah, I thought so too, and you'll appreciate it. The text message was something like that, something like, could you spare 10 or 15 minutes to sit down and talk about what to do about safe surgery and implementation of it? And I'm going, yeah, I could probably find it.
Let me think about it.
Right. And
my people talk to your people.
Right. So we sat down actually in his kitchen for 2.5 hours. And one of the consequences was we decided to charter a U.S.-based foundation. There was a U.K. foundation starting to take shape, but given the scale and particularly the philanthropic culture in the U.S., it seemed like we really needed to have a presence here. So he and I and a couple of others were the founding trustees of Lifebox in the U.S. And the reason I got interested in it in the first place was as I was coming up the ASA leadership ladder, anesthesia organizations around the world appreciated what a central driver of unsafe surgery, unsafe anesthesia was. And it made for the perfect philanthropic focus for anesthesiologists. And I kind of made it my business on my way to the ASA presidency to see that the ASA was engaged and supportive, and it felt a little bit like catching up with the Brits, who were kind of in on the ground floor. But and I'm not generally a competitive person, but I said, but I said there is no excuse for the world's largest anesthesiology organization. ASA is roughly 10 times the size of the Association of Anesthetists of Great Britain. And for us not to be carrying our share of this, and the presence of Lifebox here and so forth as kind of ASA's charity is a result of that. But the focus, I'd say, for the first 5 years, pretty much of Lifebox was rectifying the problem of unsafe anesthesia. And some of our key collaborators had done some investigations about what the oximetry gap was. So the pulse oximeter is kind of the essential patient monitor. If you ask anybody in this hall if you could only have one monitor, which would it be? I guarantee you 100% would say pulse oximeter. And the fact is, our estimate was there were about 80,000 operating rooms around the world that had none, and in many cases they had no patient monitors at all. And so we kind of recognized the potential impact. And one of the things that has thrilled me about Lifebox all along is the doable. We set our priorities around the doable. And so we created specifications for a purpose-designed oximeter for use in low-resource settings. No air conditioning, no heating, very unreliable electricity, either the absence of electricity or surging electrical power, and specified it, had prototypes, and designed it so that it could be purchased for $250, which at the time was about 20% of the cost of a commercially available oximeter. And since sourcing that, and almost entirely from donations, many from here, we have delivered 22,000 oximeters around the world in 122 countries. Now, I want to make a point about that. Dr. Aronson's office. I know.
Hello.
Is that many of the recipients of the Lifebox oximeter have minimal training. Anesthesia is delivered in many parts of the world by individuals who are not doctors, who are not nurses, and have mostly had kind of on-the-job rudimentary training. And so in many instances, this is the first patient monitor they've ever used. And so we recognize that sort of dropping it in the operating room was not the way to approach it. So in virtually every instance in which, particularly when at nation-scale delivery, there's been a very rigorous training program where we've developed multiple iterations of training tools for getting the most benefit to the patient out of the use of the oximeter that is now available. And so it's designed with a 16-hour rechargeable battery. It can be plugged in.
Solar powered?
Not yet. Not yet. But let's make note. So the first donations and distributions occurred in about 2010, 2011. And our best estimate, this is a device that hadn't existed before, was that 5-year life cycle. And I have to say, what are we, 2019 now? The overwhelming majority of that first cohort of oximeters are still working.
Still working.
I personally have been in any number of operating rooms in low-resource settings. I remember walking into an operating room in Haiti about a year or 10 months after the earthquake, and I walked in at the patient's foot. So I'm looking at the anesthesia workstation. I see a big, relatively modern-looking anesthesia machine. Wow, that's pretty
impressive.
Great. Of course, I get closer, and essentially nothing on that anesthesia machine is functional. But sitting on the counter is the Lifebox pulse oximeter, and I've just seen that over and over again, almost every place I've been. So one of the key features of it is that it's built not to require a biomedical technician to come and service it, because there ain't no biomedical technicians. And so working in that environment, that's the essential design feature. I mean, the 16-hour battery is important, and
Sure.
but the freedom from reliant, and that's the problem with that big fancy anesthesia machine.
you
I
have
saw.
no idea.
I saw.
It's a very expensive shelf.
That's what I was going to say. Storage box.
Exactly. So as I said, the connection with Safe Surgery Saves Lives and the Safe Surgery Checklist is a very powerful theme in understanding what LifeBox is about. And Gawande being Gawande and the rest of us, holding ourselves to a rigorous standard, we have had a fairly robust research envelope around this. So there's a very compelling study done in Moldova where there's a program of oximetry implementation, safe surgery checklist implementation with a dramatic and sustained improvement in patient outcomes. You're probably aware of the trial of the checklist in 8 countries around the world with a 40% reduction. And I always like to say to people thinking about implementing and using the checklist, if there were a pill that had no side effects and didn't cost anything and reduced surgical mortality by 40%, would you prescribe it?
Yeah.
And so
LifeBox is more than the device. It's the concept, if you will, which includes the training and culture of management and change.
Agree.
How do you appropriately recognize and address the nuance of what I'll call medical anthropology or the culture of delivery that is nuanced to the zip code, if you will?
So that's actually a great question, and not so much with respect to taking an oximeter and using it, but with respect to the implementation of the Safe Surgery Checklist, it's all about culture. It's about hierarchy. I mean, if you asked Bill Berry, the architects of it, what's the Safe Surgery? It's a communication tool, right. And the emphasis on everybody speaking using their mouth is by design. But there are cultural barriers. The other thing that I've kind of realized along the way is that if the checklist calls for a pulse oximeter, and by the way, that's the only piece of equipment cited in the WHO checklist, and you don't have any, that's irrelevant. If the checklist calls for sterility indicators and you don't have any, that's irrelevant. And we go down a list like that, what does the checklist mean to you? And so when I said, it being a roadmap for LifeBox, well, we provide you an oximeter. There's an element of the checklist that suddenly means something to you, and particularly for people who hadn't ever monitored a patient, saying, is the oximeter in place? And Kris will talk to you about the more holistic view to our tagline is saving lives through safer surgery, and it is about anesthesia, but it's also about a lot more, and I think that's what you're alluding to. And so we say, where are the other major sources of preventable surgical mortality?
Yeah.
So teamwork and communication is on that list prominently, and you think the hierarchy in our operating room is a powerful barrier to safe care. Think about places where the gap in education of the surgeon and the nurse is vast, and the capacity of the nurse to say, "Oh no, that's the wrong side." That's work. But another one is surgical infections, and so that, number one, is a major driver where rates around the world can be 4 or 5 times greater than we see, and is also among the doable. And you want to?
Well, let's introduce Kris.
Okay.
Yeah, no problem.
Kris Torgeson. Hi, how are you doing?
I'm fine, thank you. Thanks for having us.
Thank you so much for coming on. So tell us a little bit about yourself before you dive in here.
Sure. So I'm CEO of LifeBox. I joined about 3 years ago. My background, I'm not an anesthesiologist. I don't come from a clinical background, but I worked in humanitarian medicine, primarily with Doctors Without Borders, Médecins Sans Frontières, for about 15 years, which gave me the opportunity to see, unfortunately, many healthcare systems that really didn't have the means to be able to address key areas of care. And one of the big gaps that I absolutely saw in many of the places, whether it's a war zone, a natural disaster, or a health system under stress, through my work with MSF, was surgery and anesthesia. You very much recognize right away that is considered a luxury in many places in the world. So that if you have something that we would never even think twice about, if a child falls out of a tree and breaks an arm, they get, at least have an x-ray and get it set and properly have surgery if necessary. That doesn't happen most places. If a child is burned, if you need an emergency C-section, those kinds of things that are pretty much never taken for granted, because there's still surgical interventions and no one wants to see them happen anywhere in the world. But in most of the places where I worked previously, they were absolutely considered a luxury. So the statistic that there are 5 billion people around the world who don't have access to safe surgery or anesthesia care is a shocking one, but one that, from my background, I saw in reality. So when I had the opportunity to discuss with Lifebox and to learn more about Lifebox's work and then join the team, I was absolutely taken with it, because what I found was, first of all, a way to address a global health problem that didn't have enough actors really focusing on. The model for, I think, addressing gaps in global surgery has actually been going to do and filling gaps, which is really important, and doing surgical mission trips and doing specialist reconstructive or sending humanitarians in like MSF. But in order to really see us have a long-term sustainable impact on improving surgical systems, we really need to help work with the teams on the ground there and build up their systems so that when they're providing care, which they're starting to address them, they do it in the safest way possible. And so that's why I think Lifebox's model, to answer your question around, has always been from the get-go to work with the surgical teams on the ground. So I always say Lifebox is a surgical organization that actually doesn't do surgery.
Right.
So we're one of the only ones, because what we do is we work directly with surgical teams. So we started with anesthesia, and we were founded by two of the leading global organizations, the World Federation of the Societies of Anesthesiologists, plus the Association of Anesthetists of Great Britain and Ireland, close association then with the American Society of Anesthesiologists.
Like
so what we did,
catching up.
But what we did was, what the organization, I can't take credit, I thought was brilliant, was actually making close link with the nascent anesthesia societies in all of those countries. So in order to know where there were no pulse oximeters, so how do you know? You go to a country, you just don't want to open up a truck and say, here, take pulse oximeters, or you don't want to just go to one hospital. So you work with the Anesthesia Society, and as Dr. Hannenberg said, that might be 5 physician anesthesiologists in a country. But they've trained an entire country, but they've trained all the nurses. They know exactly which facility in their health system, whether it's a missionary hospital, it's a state hospital, is doing cesarean sections. And they can say, if we say, hey, we'll raise the money for the pulse oximeters, and we'll bring in a team to do a little bit of training on hypoxia emergencies and how to deal with them. We'll provide the pulse oximeters. Can you tell us where where you need them?
Brilliant.
So they do the gap analysis, and then we join forces, and then we know that, first of all, they're getting right in the hands of the places, and it gives that society a chance to also have a professional development. So they don't have, other than the trainings they can do, this gives them a chance to reach out to nurse anesthetists that might have been trained years ago and then gone out to a rural healthcare clinic where they're doing C-sections and never had a chance to do upgrade their skills. So we work together with them. So we've built relationships with anesthesia societies in over 110 countries with our partners. And so now we're building on that. So that really answers your question. How do we know the impact? Well, we're in touch with those societies because they tell us, hey, okay, we've got so many broken, or now we don't just need them for the OR. We need pulse oximeters for recovery room.
Yeah.
We need them for the ICU. We need them for transport. When we have something you wouldn't even think about here is that if we're sending a complicated cesarean section for surgery that we can't do in our facility because it's a complex one, we need to transport 4 hours. We want to send a nurse with a pulse oximeter so that they can address any emergency that comes up. So they lose their pulse oximeter for a day and a half. So they're asking us for another pulse oximeter. So you can see, so the relationship is key. And then through the relationships, we've also learned about some of the other gaps in surgical safety. And so it's all about teamwork and how we can work. So as the anesthesiologists say, well, it's fine if I do it, but we really need the surgeons. And then we really need the OR nurses. And we need the instrument techs. And we need our hospital manager. So Lifebox has really started to expand our programs. Now, core of our work is safe anesthesia, but we're now expanding to 2 other areas, as Dr. Hannenberg mentioned, of what we see that can really help to address the greatest causes of mortality and morbidity related to surgery, which are surgical infection rates, which here is a big issue, and then teamwork. So if we can really focus on improving teamwork and communication, and it's the core of the checklist, we know we're going to have an impact. And surgical infection, again, using a checklist-based, team-centered approach that's really a gap analysis in some ways, of identifying some of the key gaps in compliance with evidence-based practices for preventing infection, such as antibiotic timing, swab count, all those things. We can help them do instead of them just saying, hey, we have this problem, we don't know how to address it, let's wash our hands more. And we say, okay, let's take data for 1 month on hand washing, on swab count.
And teaching them.
Absolutely. The gaps in knowledge and training around degunking surgical instruments is stunning. And I just want to put a finer point on this access to care and the humanitarian missions, which I applaud, and literally hundreds of thousands of Americans contribute to. We have a crisis in the access to surgical care, and we have a superimposed crisis in the safety of surgical care. So 5 billion people lack access, 7 million die or are disabled mostly by preventable causes. So think about for a minute, if you close the gap in access and have 5 billion more operations, each one with a mortality rate 10 or 100 times greater than it should be. How do you feel about that? So, and we are unique in focusing on improving the outcomes and the safety of surgery.
You know, what did we used to say? If somebody's hungry, give them a fish. If you want them to not be hungry for life, teach them to fish. So if I may play off of the metaphor, there's more in the box than the pulse oximeter, and I think that's a really important theme. That this is a programmatic change in the culture of delivering care. And yes, there's also this device called the pulse oximeter that helps you do that, but it's hardly what's in the box. There's so much more
in the box.
There's so much more in the Lifebox, if you will.
And if I can mention that one of our newest programs follows in the same theme, is like how to engage with surgeons. So we ask surgeons, what are some of the simple things that you find frustrating and that you know are contributing to you having to delay cases or having unsafety. And believe it or not, we came up with all kinds of things, and they were like, well, actually lighting. We don't have strong lighting in our theaters and we don't have a constant electricity source in many times. Many of the emergencies are C-sections at night, and we can't find the person to turn the generator on. And the headlights, the surgical headlights in most high-income countries are in the many thousands of dollars and are not accessible to them. So they usually make do with camping or bicycle lights, which are great.
Or cell phone.
Or holding a cell phone,
field.
Which when you have one OR nurse, having them hold the light, the cell phone is not the best use of a manpower or woman power. And so we've actually then listened to them. We put together specifications for a purpose-adapted surgical headlight.
Lifelight.
We are calling the Lifelight actually. So, and we'll be hopefully announcing it.
And it's going to be yellow like the oximeter.
Yeah, and that it's exactly as you're saying. It's not just a tool that's essential to their work, so they can really focus. It'll be high intensity light for deep cavity work. It will be long-lasting battery, light for them to wear in high heat, etc. It won't be perfect, and it'll be a low cost that we can either donate or raise funds but the same thing, we hope it also engages the surgeons. So if you're going to, if we're going to like work with the Surgical Society, we're going to say, can we do a checklist implementation strategies? Can we have the surgeons the surgeons, when they turn on their headlight, will they start to say, okay, let's do the timeout and let's do
that's cool.
We're thinking of different ways to do that. So as you described it beautifully, it's not just the tool. So we say we do tools, we do training, and we do partnerships, and those three work together to really help improve systems.
I've always loved the theme of connecting. It's to me intuitive, but not necessarily to everybody. But perioperative medicine is population health, and this speaks to it at a early part of the curve. I just can't help but think of the theme today.
Yes.
An hour ago we talked to somebody about augmented intelligence and how that will influence. So, the Gaussian distribution of gap is real, and it scales from literally one end to the other. But our opportunity, how do we help you?
That's what I was just going to ask.
How can we communicate to the many, many people who download what they can do to get involved?
Oh, great. Great question. Thank you very much.
They're closing us down.
Yeah, they are. They're closing the lights down.
Yeah, so how do we get in contact?
We would love you to, part of our work is about awareness raising, so even learning about it by looking at www.lifebox.org. So we have resources about what the global surgery and anesthesia gap is, and we, of course, could use donations. So we're raising funds here at the ASA. We've put on an ASA Residents Lifebox Challenge, and we raised
some of the Lifebox residents.
Yeah, we've had the residents raising funds for us that are going directly to our pulse oximetry work. So here we've raised funds for about 300 pulse oximeters that are going to go to some key countries that we would not have been able to do that work without. So we could really use financial support. We also are interested in people who are interested in volunteering with us, who are interested in that type of quality improvement work, want to work with the systems, possibly do training. More and more we're doing training of trainers types of workshops. So we really are interested in people also with language skills, etc. So if you go to our website, send an email. We're a small team of only about 12 people, but lots of force enablers by having many people around the world.
And the website again is?
www.lifebox.org.
Yeah, LIFEBOX.
Lifebox.
Guys, I honestly, we could probably sit and talk all night long about this because it is fascinating, and what you guys are doing, it's unbelievable. It's really
thank you.
Yes, thank you so much.
This is why we do what we do, and to all of us listening to you, thank you.
Yes, thank you.
Thank you for having us.
A pleasure.
Yeah,
absolute
hopefully
pleasure.
We'll have another time. We'll have another chance and opportunity to sit down and talk to you guys to see how the lights are going.
Yeah, we'd be happy to.
All that good stuff. So wrapping it up today, it's been a fabulous day at ASA, the Anesthesiology 2019 Day 2. We have one more day tomorrow. We're going to be coming to you at 9 o'clock in the morning, or 9:30, I think, until about 1. So be sure to tune in tomorrow. Again, thanks to our sponsors, Edwards Life Sciences, the ASA, and all those people that are interested in helping us share the word and spread the knowledge and these messages, just like what you guys are doing with Lifebox. So thank you so much. Thanks for listening. We'll catch you tomorrow. Cheers.
TopMedTalk.
Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.topmedtalk.com.